and the role of religion in the community. So what I took from that was that context and understanding the context, it matters. A couple of years later, I also had the opportunity to partner with a colleague who was serving the Asian American community in Boston, who was really trying to understand the increasing rates of smoking within that particular community. So when we went to look at the literature, there was very little. In fact, it showed that there were lower rates of smoking among Asian Americans compared to other racial groups, nor did it necessarily break it down by ethnicity. And there are large sort of Southeast Asian communities in Boston. So in working with Dr. Atencia Amaro and also with the Institute for Asian American Studies, we designed a study to look at what were the risk and protective factors in this community, what were the challenges and supports that residents were dealing with and coping in their communities. And what we found was that in particular for the Vietnamese community among males who had recently immigrated to the US, that they had left their families behind and were using smoking as a way to cope with those experiences, and also using smoking as a way to greet other people and to form sort of a community of men to lean on and to support one another. So what we found out is that it was really not, the emphasis was on better providing mental health services and social support for this particular community. But as it turned out, we did have to leave the data with the community partners, given that the resources had ended. So the next couple of obesity studies represent examples of research and community partnerships with a strong infrastructure of support. And particularly, there was a study that I was involved in that was an extension of a program in Philadelphia out of the University of Pennsylvania and the Department of Education, with an established sort of relationships and partnerships with the schools in Philadelphia and also in Trenton. And they were interested in expanding these programs to middle school students and to elementary school students. So the community engagement and partnership was actually reflected in the theories that were used and in their approach. And the theories sort of emphasized, well, how are children making meaning of the experiences that they were having in the communities that they were living? And that these experiences were normal given the environments that they were living in. So how do we better design sort of instruments and the research questions to reflect the complexity of the issues that they were experiencing? So although there was a strong sort of infrastructure of support, the expectation was also that I immerse myself in the Philadelphia and the Trenton community. So that meant working and collecting data in the school systems. It also meant conducting sort of windshield observations in communities to better understand the experiences that students were having from getting from one place to the other. And it helped to inform a sub-study within middle schools and elementary schools in Trenton. And the purpose of this study was to examine factors associated with overweight and obese status among African American and Latina girls, and included both a qualitative and quantitative components. Again, to better understand some of these underlying factors that were contributing to obesity. Participants for the sub-study focused on the 4th through 8th graders, but we did look at sort of translating these measures for also for 1st through 3rd graders, for the kindergartners, for 4th and 5th graders, and through 6th through 8th graders. The majority of African American, or 45% of African American girls were overweight, 62% of Latinas were overweight, and they did come from low resource environments. But what it enabled us to do was to be able to partner with individuals in the community to help us to better tell the measures that we used. So for example, for the body satisfaction measure, of actually working with individuals who are artists in the communities to help us design the measures to be more specifically appropriate for African American, Latina, and Asian American girls. Again, sort of after that data collection, though, phase and the resources ended, I had to, again, sort of leave the data with the partners, but it was actually used to then train and provide support for staff, teachers, and administrators, and providing better support for students. So similarly, with the Stanford Prevention Research Center, there was also an infrastructure of support from sort of statisticians, data management, the project directors that came directly from the community of Oakland. This particular study, the Girls Health Enrichment Multi-Site Study, was a randomized controlled trial of 8 to 10-year-old girls. But again, sort of in understanding the community of Oakland, the actual intervention took place in the homes of girls in the Oakland community. So it meant height and weight was taken in the home, as well as blood samples and surveys. The other component in terms of the dance program took place within the community to address the specific needs and challenges that many children had. Again, these families came from low resource environments. So again, taking that into account in the measures that were used and also the data collection process. But these experiences, in addition to sort of immersing myself in the Oakland community, which meant going to offer additional support for a mobile market that had been converted from a postal truck to better understand, to reach more of the community, to starting a work group in the San Francisco area and working with grocers, as well as colleagues at UCSF, were sort of important experiences working in the free clinic to better understand the needs of the families. But this helped to lead to, again, another sub-study of looking at the relationship between BMI and depressive symptoms. Some of the measures that we looked at were better understanding the role of ethnic identity, as well as self-esteem and overweight concerns. But as far as sort of, how does this contribute to creating better community academic partnerships, some of the lessons learned included the time that's really needed to understand the complexity of the problem. So other work in terms of working in Detroit with the Samaritan Center that provides wraparound services for residents in the community, it means it takes time. It takes time to develop common goals, to develop relationships and trust. And that it is important to have an infrastructure of support if possible. But often we tend to go to the same partners, and often they get frustrated, and nor do we necessarily get an extent of sort of the diversity of experiences within communities. It's also important, I think, in terms of partnering with communities to develop instruments. Sharing results with all partners, and also this idea of sort of publish or perish that we tend to have in the academic setting, and that how do we better value the time it takes to develop the relationships and trust, and better understanding, again, the complexity that leads to these specific health outcomes of interest. So one approach that has helped in the past is to include all the partners in the publication process. So we often included the data collectors, the project managers in the publications. And funding, changing the funding process is another sort of lesson learned. How do we support not only the participants, but the staff, the researchers, and investigators? Thank you.
Good afternoon, and I know I'm holding your lunchtime, so I will try to be brief. I'm Rosa Colon-Colaco. I'm the Senior Vice President for Christiana Care Learning Institute and the Chief Diversity Officer. And I just want to share some of my journey of research myself. I started doing research in 2002, and when I started looking at the great work we're doing here, I did a lot of research in Latin America, Asia, in Europe, and we were looking into language, the role of language, and also how can we build knowledge, the building of knowledge and knowledge creation. So what I would like to do in my insight today is to shift a little bit the conversation about action science and action learning. When we talk to someone about research, there's so many different definitions out there. And many of our community, when you try to connect with communities, some language get in the way. I think we have a great opportunity through this grant to build hope, build knowledge creation, build connection with our communities, or we can get people very confused of what this work is about. So that's really what I'm trying to address today. At Christiana Care, we created a learning institute as a way to use action science and action learning to connect our community of learners so we can build equitable care and we can deliver equitable care that provide value to our patients. So what does that connect it to this grant? I see a lot of great connection. And for example, one of the things that we've been working on for a while, and I have some examples in the community, in addition to my role at Christiana Care, I've been appointed by the Delaware governor as the chair of the Delaware Health and Social Services subcommittee. And every time we have a strategy, what I would share with you is to really connect people through action research to come to learn about different aspects of not only their health, but also the education and other challenges. So when I go out there, really, I don't mention too much the word research. In reality, we're really doing research because we are getting people to get connected in a common ground of their interests to look into, and not only look into, inquiry into what are the challenges that we have in our community or Hispanic community, and find solutions by working together in defining within their language what it is. And when I'm talking about language, I'm not talking about Spanish and English. I'm going to give you one example. We developed a kind of a survey instrument to inquire more about Hispanic community, about their priorities. We asked very simple questions that for me were very simple. We translate them in Spanish for them. So when we start testing the instrument, a simple word as goals, which is really metas in Spanish, it was very simple for me thinking that they would understand what we're talking about. The reality is that there was not really a real understanding what goals really meant for them. So in reality, we needed to translate some of that. So one of the things that I'm asking all of us here is, what is our strategy for learning, the learning process for the grant? It's not the learning process about the clinical aspect of the grant, but more about the research process that can really connect community in a way that they don't feel that this is about, I'm going to become a guinea pig of somebody's work. Because sometimes that's really maybe the first reaction. But if we connect this into, we're going to learn what is research in the community in a literate way, that we can connect that to the health delivery process, also to outcomes, so they can really connect to what are we talking about. So that's what I really call action learning. So the community will come because they really want to learn, but they want to learn not only about what we want them to learn, but really we would like them to see that they can learn about each other. Sometimes by sitting together with people like in the community, sometimes people will realize and have a lot of wisdom, oh, I'm not the only one with these challenges. It's not the only Latin American community that have these challenges. The other people in Delaware may have a similar challenge. So I think the action learning process is really connecting people to the work, so they can not only learn from one another, learn from all of us, but finding that common ground, and also finding solutions. In many cases, those solutions can become theories. Those theories can be action learning theories. It can be clinical theories, but in many cases, may not only be clinical theories, and I think that's really a great potential that we have. So this is the action learning process that we've been using in the community, and it's really to asking questions and powerful questions of inquiry. And this is for a research on this field. I used this for more than 4 years in my PhD dissertation around different countries. And it's to allow communities to really look into the inquiry process themselves. So what does that mean to me? In my context, in my reality, in my mental model, and then start having active listening sessions. And what I having here is we've been using a social media instrument. So we have Secretary Landgraf within our premises 2 weeks ago, and she has agreed to be in our committee. And we've been looking into how can we really listen to different media. Also, I think sharing the learning and also the reflection is really important here, because when people go away after a meeting, all of you are going to go away thinking about what happened today. And I think the reflection process is where knowledge creation can also take place. So we look into we will continue this process of data collection, and I will share with you some of the examples we're doing. We're also going to have a Delaware Latino Summit for the governor for the first time in Delaware. And we're looking at appreciative inquiry, which is also another action science process to enable people to understand more the positive psychology versus start looking into we're going to come together to complain about what is not working. Is how can we create a different reality? How can we come together to create what is possible, and what we think what is possible then connected to the work. The community conversations is in different areas of Delaware. Not everybody will come to Wilmington to have a conversation. So we are being in Seaford, in Wilford, in Milford, in Georgetown, all the different places where people want to do the work, collecting their hopes, their dreams, their challenges, and then looking into using that data to really design the Latino Summit that will be a whole day, November 13. I'm also the vice chair of the Latin American Community Center, and one of the things that we've been researching there, and we did a lot of work with the leadership. What is leadership? I think Dr. Bauer mentioned leadership, the role of leadership, which is so critical. So what is the role of leadership in a non-for-profit organization? So what is the role of leadership promoting health and social services? And to the community conversation, we have asked them to prioritize their challenges. And I've been surprised to see that health is maybe priority number 4 so far. So we will continue having this conversation. So the question to us is, we may go out there to get people more engaged, but maybe health may not be a priority they see as a number 1 priority. So how can we start getting to learn more about within their context, what is their priorities? Also in the Christiana Learning Institute, we've been looking into language services and what is the role of language in connecting with people, connecting with what is respectful for different audiences. Also, what is the impact of language services into outcomes and patient experience. And we also use a similar tool, a similar action science process to make it happen. So just in summary, is I think I challenge all of us to think about what is the learning strategy for the grant. And it's not only from the clinical side, but what is the process to engage our community. I think we can excite people. I think we can get people to learn more about, when we talk about research, what does that mean to them? Because we have our own agenda that we would like to build with them. I think it will be more powerful if we think about a learning process to allow all of us to learn more about research in other literacy settings. So thank you very much.
So hello. I wanted to talk today a little bit about engaging the community from the physician's perspective. 4 years ago, the Academy of Pediatrics partnered with NICHQ, the National Initiative for Child Health Care Quality, to look at how to increase physician engagement with their communities around community-based healthy weight promotion. And I'll start by saying that we asked teams of physicians from across the country to come and participate in training, bringing their community-based teams. And that was 4 years ago. And just so you get a sense, I'm going to share some of the materials with you, but just so you get a sense of the outcomes of that training, the physician, Chris Bowling from Kentucky, who came with his team, went back home with his community partners, built a community foundation that is now working actively with communities in community change around healthy weight promotion, and he was the catalyst for that. Steve Pont from Austin, Texas, went back after this training and built his community coalition so that they now are running a CMMI grant for community-based weight healthy weight and obesity prevention. Marsha Rollerson, a physician from Bruton, Alabama, went back with this training and engaged her hospital in being a major partner in community-based change and community participatory research. So with that said, I think for many physicians, community engagement means advocacy. And I think we want to think about when we approach physicians and healthcare providers that for them it may not be research at first. It may be advocacy is a stepping stone to help them get involved in their communities, because they can be the change agents in their communities. They really are trying to translate evidence-based practice into practice. And obesity is sort of the paradigm of a condition where it becomes inherently obvious very quickly that you need community partnerships to get this work done. So when we first met with our physicians, we acquainted them with just strategies for community change, and you can see those there. We discussed with them why community action was important, and you can see it provides the physicians an opportunity to really create broader systemic change, to work in the policy arena if they wanted, to continue their educational efforts and raise awareness, and collectively gain the attention of decision makers. So when we think of healthcare and public health professionals as change agents or as advocates, what they really have to be reassured about often is that they do have incredible credibility, and credibility outside their clinical situations by position, reputation, and their experiences. So a clinician walking into a school board meeting and trying to engage them as partners can be a powerful thing. They often have strong relationships with community members by virtue of their position in the community. Many are small business owners, but also by the relationships they have with the folks in the community who are in their practices. And they have a skill set that works well for them in establishing community coalitions. They don't always realize that this is the same skill set they have every day that they use to establish trust and develop relationships with their patients and provide solutions. So healthcare providers are often very solution-oriented, and this works well in a community setting. And then strength in numbers as they work together in their communities. And often I say this, and it could be obvious, but often providers need to be reassured to take that step out in the community. They do have a lot of skills already to do that. The other issue in really trying to engage providers to do this work, and remember we're talking advocacy, but as you can see from my examples, advocacy turned in to both coalition building, resource and capacity building and research, that they can affect change without requiring a lot of time. They can do it. There are many advocacy guides for physicians that show them how to advocate in small bits of time. They can prioritize their interests, and they don't have to work on every issue. And we talked about getting overwhelmed. They need help and sometimes prioritizing. And they really can have help identifying the key stakeholders to make those connections in their communities. They also need, and we'll see in a minute, a tool we created to know what else is being done. So you don't want to have to reinvent the wheel. There are plenty of community engagement strategies around obesity, for example, that have been evidence-based, used and researched, and can be built upon. And you can see lots of those opportunities in this slide where providers have been engaged. And they need to really understand that there is power in team building and coalition building, but they can start with who they already know. So sometimes a provider or a physician will think, I have to go to the highest level. They often know lots of these people in the community already, and they have these natural connections that they can build on, and they can be advocates. And physicians don't work very long in the community and don't work very long seeing the problems their patients have without feeling an urge to advocate for the help that their patients need, that their patients can't do that for themselves. They also need to understand a little bit, and we help them with understanding why they needed a bigger coalition to work in, and this is to increase your resources and capacity, to build diversity into what you're looking at, really to create visible and wide-ranging support in the community, and again, demonstrate that collective power, that if you're trying to influence decision makers around community change, you have more power to do so. I'll just briefly share with you a tool we created, not for this training, that we created this before, which is really to link what the clinician was seeing around obesity in their practice to policy and practice change that they might make So you can see on the left-hand side, 5210 breastfeeding BMI, 5 fruits and vegetables, 2 hours of TV or screen time, 1 hour physical activity, no juice, breastfeeding, and BMI. This is a policy tool that if they look across the top, they can see, I want to get involved in practice change. And we talked earlier about the difficulty of practice change and the importance of practice change, the importance of doing research and collecting data on effective practice change, community, school, state, or federal, and they can look at those little blocks and find the MAP strategies from the CDC, and they can drill down and find action steps that they can take derived from those MAP strategies, and they can drill down further and they can find out who recommended those, where the evidence is for those strategies, and how, who's done projects and how to replicate these projects in their communities. So I think we also have to think about how we give our folks tools to have that community engagement, to go from the world that they're in as clinicians to the world of community engagement, whether it's policy or community change. And I think this may be a good pre-step or a good way to think about how we're going to promote community engagement even before we're asking them to do our research projects. And so I just leave you with some of the strategies that have worked, and as I did this talk, I reflected in 4 years, the physicians that had this orientation and brought teams actually were able to do a lot of capacity building, resource gathering, and even begin to engage in resource after this. So thank you very much.
So now we have an opportunity to listen to you and for our panelists to respond. So questions?
This question for Rosa. I was wondering what the first 3 priorities that the Latin American community were interested in, and how do these 3 priorities affect their healthcare decisions?
I think that number 1 priority is having work, having a job to be able to pay for the basics, to then be able to afford maybe sometime going back and refill their medications, education, and the third is going back to the immigration law. So sometimes that's more like basic for them. And they may not see that that can really have impact into health, but that's within their context. And we're gonna have more data collected in the next couple of months. So that may change as well. Thank you for asking.
Next.
Hi, Dr. Hassink, you mentioned advocacy as being a really key component in particularly physicians' ability to engage with the community. As we move down this road of paying for value rather than volume in healthcare, and we do certainly see, and this was mentioned, I believe, by Dr. Manus earlier, this convergence or particularly mergers of hospital systems, groups buying up physicians from the community and putting them into ACO arrangements or integrated networks or whatever it might be. Do you see that actually limiting individual physician's ability to advocate for their patient if it's not in line with the particular group think of whatever organizational setting they're within?
Oh, Brian, thanks for that question. I actually think this makes it even more crucial that physicians and healthcare providers align with communities. Absolutely crucial. Mm-hmm. Because if they don't align, I think your perception is correct. They lose touch with what the needs of the community are. I think the triple aim is wonderful. I think we're getting a little overloaded on the cost down model here and forgetting some of the other aspirational and important things about population health. So I think this alignment with community is an actual strategy for us moving into healthcare reform that will keep the target of population health on deck. And I think if we don't do that, we're going to get driven in a cost down model that's not going to serve anybody well. So thank you for that question.